What is dysarthria and how to manage it? Ways to assess dysarthria. One of the most difficult moments as an SLP is when you meet a patient who's suddenly or gradually unable to speak the way they once could. Understandably so, patients who struggle to speak often find themselves navigating feelings of frustration and isolation. Today we're going to specifically be talking about dysarthria and what MedSLPs should consider when assessing and assisting in the management of dysarthria. Let's dive in. I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education. What is dysarthria? Dysarthria is a motor speech impairment that affects speech articulation. Language comprehension and expression remain intact unless there are comorbidities that impact language. So when you hear dysarthria, think about speech and articulation. Dysarthria results from an impairment in the motor neurons, neuromuscular junction, brain areas supporting speech feedback control like the basal ganglia and cerebellum, or the speech musculature itself. Impairments to these structures most often result from strokes, but they can also be a result of traumatic injuries, tumors, degenerative processes like Parkinson's disease, Huntington's disease, multiple sclerosis, and transient impairments like Bell's palsy. Dysarthria is classified by the neuroanatomical structures affected and can affect any of the speech subsystems such as respiration, phonation, articulation, resonance, and prosody. Now that you know what dysarthria is, how do you approach patients who come to you with symptoms of dysarthria? Start with an oral MEC cranial nerve evaluation. Your findings on your cranial nerve exam will help you create a hypothesis about dysarthria type. For example, a patient with a facial droop and lingual fasciculations will have flaccid dysarthria, but a patient with masked facial expression and rigidity will have hypokinetic dysarthria. ASHA breaks this down further on their practice portal. I know we are so used to doing cranial nerve exams to diagnose dysphagia, but there is so much that we can learn from cranial nerve exams to help support a diagnosis of and treatment of dysarthria. An SLP friend of mine once had a patient who had a pacemaker that was not compatible with an MRI. He presented with a subtle right-sided facial droop and acute onset of severe dysphagia. When she evaluated him, she also noticed the patient had mild ataxic dysarthria. After sharing the oral motor exam results and video fluoroscopy findings, which revealed severely impaired UES opening, the neurologist was able to use this information to determine that the patient likely had a small brainstem and cerebellar infarct that was not showing up on the head CT. The information this SLP gathered on her cranial nerve exam also helped her develop a plan of care for this patient in dysarthria therapy. Now that you know how to assess dysarthria, it's time to determine your treatment plan. Do you know what the number one goal of dysarthria treatment is? Keep watching. We'll be talking about that next. Plus, there's a freebie coming at the end of this video for all of you who stay till the end. Formal and informal measures. Have a mix of both formal and informal dysarthria assessments handy. Having a few assessment options at your fingertips will ensure you have the diagnostic tools you need. Not every patient is ready for a formal measure right off the bat, like the French Dysarthria Assessment or FDA 2nd edition, or the Dysarthria Examination Battery. So have an informal assessment available too, like the Informal Dysarthria Assessment from the Mayo Clinic. Remember, when you're assessing dysarthria, you need to look at the 5 domains of speech: respiration, phonation, articulation, resonance, and prosody. I'm going to share a brief overview of common characteristics of different types of dysarthrias you might encounter as an SLP. Flaccid dysarthria. Distinguishing characteristics for flaccid dysarthria include breath voice, imprecise consonants, reduced speaking rate, reduced range of motion in articulators, tongue fasciculations, diadochokinetic rates, or DDK rates. Spastic dysarthria. For spastic dysarthria, you're likely to observe a strained or strangled vocal quality, grunting at the end of phrases, and slow DDK rates. Unilateral upper motor neuron dysarthria characteristics include unilateral facial weakness, flattening of the nasolabial fold, articulatory imprecision, and a harsh vocal quality. Hyperkinetic dysarthria can be characterized by involuntary movements at rest or during speech, articulatory breakdowns, and involuntary vocal fold abduction and adduction or voice stoppages. Hypokinetic dysarthria will commonly present with reduced loudness, short rushes of speech, flat pitch and DDK rates that may be fast and imprecise. Ataxic dysarthria is often characterized by slurred speech with a scanning intonation pattern, irregular articulatory breakdowns, and hard voice. Knowing the patient's diagnosis and, if possible, site of lesion, if there's a stroke or tumor, can also contribute to the investigation process. For example, we know that Parkinson's disease often results in hypokinetic dysarthria given the basal ganglia involvement. Remember, you don't have to complete a lengthy formal assessment on every single patient. Having a mix of informal and formal exams paired with your chart review can take you far. One SLP friend of mine told me about her time as a clinical fellow when she tried to do the FDA-2 on every patient she ever encountered that had dysarthria, even if they really could not participate in that in-depth of an assessment. Particularly in acute care, patients may not have the time or energy to sit through lengthy formal assessments. Once she became more comfortable with informal assessments and chart reviews, she was able to leave the FDA-2 behind much more often and still create effective therapy plans for patients. Now, I will say that depending on your facility and the patient's payer, you may need a formal assessment to justify therapy. But if you don't and it doesn't seem necessary, then use your clinical judgment to make that call. Determine your treatment plan. Remember the number one goal of dysarthria treatment. The goal of treatment is to improve the area of speech production that will have the greatest impact on your patient's intelligibility. You don't need to improve every little thing about your patient's speech. This could look like working to improve respiratory support, resonance, phonation, articulation, and/or prosody, but not all 5 areas all at once. Kick any non-speech oral motor exercises to the curb. Just as a reminder, your dysarthria treatment should not incorporate non-speech oral motor exercises. There is very little research to support the use of non-speech oral motor exercises to improve speech intelligibility. According to ASH's practice portal on dysarthria, treatment can be restorative or aimed at improving or restoring impaired function, and/or compensatory or aimed at compensating for deficits not amenable to retraining. Restorative approaches focus on improving speech intelligibility, prosody, and naturalness and efficiency. Compensatory approaches focus on improving comprehensibility by increasing the speaker's use of communication strategies, improving listener skills and capacity, altering the communication environment, and increasing effective use of AAC and non-AAC devices. The ASHA Leader article by John Rosenbeck called Mind Over Motor outlines suggestions for therapy beautifully. Here are his components for cognitive motor dysarthria treatment. Component number 1, recognizing differences. Help the patient recognize how their speech is different and what makes it difficult for others to understand. Number 2, willingness to change. Use motivational interviewing to ensure the patient is willing to change or work on their speech intelligibility. Number 3, setting goals. Keep the patient involved in the process. Determine their goals with them. Number 4, talking therapeutically or flipping the switch. The patient and SLP agree on a subtle sign to flip the switch. During this time, the patient practices talking using whatever strategies the SLP has suggested. Number 5, learning to listen, evaluate, and self-correct. The client learns to self-evaluate, which helps with generalization outside of therapy. Definitely read along in the article to learn more about how this works. It can be complex. Number 6, add cognitive linguistic load. Per Rosenbeck, dysarthric speech adequacy declines with situations of greater cognitive linguistic load, such as talking in a crowd, explaining a difficult notion, or speaking while hurried or distracted. Practicing under the best approximation of those conditions is important to generalization. SLPs and patients could practice with volunteers as new conversation partners, have the patient tell more complex stories, or respond during or after distractions. Lastly, if you're really wanting to learn more about dysarthria, I can't recommend the Duffy textbook enough. We'll post the citation for it below. But it's fantastic for learning all about assessment and treatment options for something I really wish I knew a lot more about while working in the nursing home setting. Motor speech disorders like dysarthria can feel so tough to figure out. So keep the resources from this video at your fingertips, your eyes on the literature, and your mind open to mentorship from other SLPs. You've got this. Check out the MedSLP Collective resource on dysarthria assessment and treatment considerations. The link to the MedSLP Collective dysarthria resource is in the description below. Want to dive even deeper and seek support from mentors, webinars, journal club discussions, and a community of over 6,000 other medical SLPs? Become a member of the MedSLP Collective by going to medslpcollective.com today.